Hi, everyone. We're going to get started at a couple minutes past the hour. So we'll just give people a moment to join from wherever they're calling in from. Hi, everyone. We'll get started in a minute. Thanks for joining us this afternoon, this morning, wherever you are. Okay, let's get started. Hi, everyone. My name is Rebecca Penn, and I live in Mi'kma'ki, Nova Scotia, and I'm the project manager for the Substance Use Health Network. And I'll be your host for today. So I see we still have some people joining us. I'm really grateful that people have taken time out of their day today to come and have this conversation with us. Um, First, I'd like to start off in a good way. In the spirit of truth, reconciliation, and respect, I'd like to acknowledge the land where I live, Sogum Gigum, colonially known as Shelburne, Nova Scotia, which is part of the traditional and ongoing territories of the Mi'kmaq. I invite you to share in the chat where you are joining us from today. It's neat to see where people call home or where they are currently living. And it's great to also learn other names of the colonial names that we know or are most familiar with. So I want to take a moment to reflect on what brings us all here today and how it connects to truth and reconciliation. We work in a sector whose goal is to address social and structural harms. And we recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking that continue in our daily lives. We know that Indigenous people, as well as members of African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. So I want us to remember always that colonialism is with us today and take this opportunity to recommit to showing up in our work and striving to transform racist and colonial institutions and practices, to repair those harms, prevent future harms, and to work towards a more inclusive and equitable and just future. For those of you who are new to the Substance Use Health Network, you may have known us as the National Safer Supply Community or Practice. But we are now the Substance Use Health Network. We're a knowledge exchange and capacity building initiative that emerged or grew from the National Safer Supply Community or Practice. Since we became the Substance Use Health Network, we've had a few hundred people join us. So we're now over 2,000 people. And our membership reflects every province and territory and also some countries outside of North America. Our membership is committed to expanding access to an evidence-based continuum of substance use healthcare options and advancing drug policy that's rooted in the rights and realities of people who use drugs. You can check out our website to learn more about what we do. I also want to give an opportunity for Tanya from Reclaim to say a little bit, or Tanya, I'm putting you on the spot here, but I did have a slide here. Right now, the Substance Use Health Network has been operating, or the way we've been able to continue doing work over the past year outside of having any funding has been very much a labor of love, supported by Reclaim Collective. So I want to give a shout out to Reclaim for the support, the labor, the time, and the care that they have given to the Substance Use Health Network. And just, make sure everybody is familiar with Reclaim and their work. Tony, do you want to say anything, or you can leave it with the slide if you like, because I am putting you on the spot.
You are, and it's good for me because no, thank you. You've said enough, I think, but I am very happy to be here, and I'm very happy to have been part of this, being part of this community of practice for years now. So welcome everyone, and nice to be here. Thanks, Rebecca.
Thank you. And if you're interested in finding out more about the services that Reclaim Collective offers, please have a look at their website. So some quick housekeeping. We are recording this event, and we will share it on our website and on our YouTube channel. There is English closed captioning enabled. We're going to have a presentation, and that will be followed by a discussion. If you have questions you'd like to ask our presenters, please pop them in the question and answer box. The question and answer box lets us keep track of questions. If you put them in the chat, we might lose them. So yes, questions or comments for the discussion can go in the Q&A box, so we'll find them when we come to the discussion time. And we'll do a poll about halfway through the presentation that we'll use to help inform our future directions. And whoops, sorry, I've gone too far. Hold on, I've got one more slide to show you. So I also want to let people know about a presentation, or our next webinar that we're doing in April. But first, let's talk about why we're here, why some of you have come today for this specific webinar. I think a lot of us are really wanting to gather and talk and connect with each other right now, because we're at a time when harm reduction services across Canada are being scaled back, defunded, delayed. We're seeing this with safer supply programs over the past couple of years, but also supervised consumption services and other harm reduction interventions and organizations. And these policy decisions around funding and support, these are reshaping the landscape of care in Canada. And they're really raising urgent questions about evidence, ethics, and responsibility. So today we're focusing on the final evaluation of the MySafe program. This is not just about one program, though. It's about what happens when a model designed to reduce harm, improve safety, and connect people to care is implemented, and what's at stake when support for these approaches is suddenly withdrawn. So our webinar today is really the first in what's turning out to be a two-part series, and maybe it'll be more parts, that I'm loosely calling What Happens When Care is Taken Away. So the focus today is safer supply. The next webinar we have in April will focus on supervised consumption services and emerging evidence from closures, specifically within the Ontario context. So together, these conversations aim to ground policy debates in real-world data and lived impacts. And while some of the information that we'll learn in this report today and also in the webinar in April, some of the research findings won't surprise us, but having that research there does provide us with important ammunition for our advocacy work. So I'm really grateful for those of you who are tuning in today, and for sharing these reports and research publications. So coming up in April, we'll continue this theme about what happens when care is taken away. And we're going to have a presentation about preliminary findings from Ontario SCS closure studies from the CRISM Ontario node folks from the Margins Lab and CRISM, yeah. So sign up for that. Um, and I hope that we'll see you on April the 23rd. And with that, I'm going to pass it over to our, I can't find my stop share button. Sorry. Oh, I'm not even sharing my screen. Haha, I missed it all. I had such a nice PowerPoint presentation. That's okay. Yeah, I'll pass it over to Isabelle, Kaitlin, and Tara. Thank you for coming and helping us out with this webinar and sharing this important report.
Yeah, of course. Thank you so much for having us again. I'm just going to take a moment to share my screen, get our presentation up and running. Okay. Can you see the presentation okay? Yep, awesome. All right. Hello, everyone. Thank you so much for joining us today. For those of you who attended our previous webinar back in January, we might be familiar faces and names. We presented on another collaborative product back then called the Shared Purpose Guide. But today we are back again to present on another product that came from that same collaborative partnership, which is the MySafe Impact Report that Rebecca has already done a beautiful introduction to. But this presentation today is really going to walk through the findings of the report, which is an evaluation of Canada's first biometric safer supply program. And the findings specifically look at the impacts of the closure. Before we begin, I'd like to acknowledge that Changemark's work takes place on the unceded, ancestral, and stolen homelands of the Musqueam, Squamish, and Tsleil-Waututh nations, as well as across Turtle Island. As we talk about the impact report today and its findings, it's really important to remember that healthcare and research and related systems have been tools of colonialism, and that this legacy shapes the inequities that we continue to see today. And that supporting Indigenous sovereignty means centering Indigenous voices, leadership, and self-determination in their care and in their participation in how research is designed, implemented, and shared back with the community. Before we get too into the presentation, we're just going to do a round of brief introductions. So like I said before, those of you who attended the last webinar might already know who we are, but for those of you who did not, my name is Kaitlin Calligiari. I am gratefully joining today's call from the traditional ancestral territory of the Anishinaabe peoples of the Three Fires Confederacy, as well as the lands of Caldwell First Nation under Treaty Number 2. I'm a project manager working with Changemark Research and Evaluation. So just a little bit of information about Changemark for those of you who aren't super familiar with us. Changemark is a woman-owned, social purpose-driven contract research organization. We specialize in mental health and substance use research and evaluation. Our goal and really just how we conduct our everyday work is to put people and equity at the center of all the work we do and every single project we take on. We really firmly believe in the power and the importance of elevating community voices and working collaboratively with folks impacted by issues so that we can build better solutions with them and improve the well-being of those communities. I've been working in this space with Changemark for about 4 years now. I hold a master's of public health, and prior to working with Changemark, I worked a bit more broadly within the public health system in Ontario, where I am located. But I will turn it over to Tara now to introduce themselves.
Hey all, my name is Tara Taylor. I do most of my work, and today I'm calling in from the Musqueam, Squamish, and Tsleil-Waututh Nations. Grateful to do the work here. I've spent about the last 20 years working in Vancouver's downtown east side, currently as the executive director of SpenceCreo. Just the name SpenceCreo wasn't a part of the MySafe world. Just MySafe was something I did off the side of my desk. A big part of what SpenceCreo does is very peer-driven, person with lived experience driven, providing wraparound supports to folks that are peers working at a lot of our health authorities, harm reduction initiatives. And so a lot of that was parallel alongside, or somehow we also were able to like refer folks from SpenceCreo to the MySafe project. So that's kind of where it blends over. before we really get into any of the rest of the presentation is we are in a kind of a messed up time. Things are being cut, things are scary. And myself, I wouldn't have the career that I do in Vancouver if there wasn't organizations like Vandu, even Indigenous peoples and collective care. Like this isn't new that community needs to come together and get creative. It doesn't mean that it's not hard, it doesn't hurt. But yeah, I just really want to throw out that I only get to do the work that I'm doing in these creative and innovative ways because organizations like Vandu and stuff before were there 30 years doing the creative stuff in the alleys, handing out needles, opening up windows, being kicked out of spaces, their next place for rent. So yeah, just a shout out to the folks before us, so that we're here today doing the work that we're doing.
So thank you, Tara. Hi, everyone. My name is Isabelle Boisvert. So I'm a knowledge translation and community engagement consultant for Changemark. I live and work on the traditional and unceded territory of Tiohtià:ke in Montreal. Sorry about that. Home of the Kanien'kehá:ka Nation. And as an uninvited settler, I acknowledge my responsibility to act and work with respect, reciprocity, and inclusion. First and foremost, I'm a person with lived experience. So for over 15 years, I was using drugs and alcohol really heavily. I was smoking crack cocaine and injecting opiates daily. Over the years, I was on methadone, on Suboxone, which really helped me in getting to where I'm at today. But I definitely experienced the challenges with observed dosing in pharmacy settings. And I've been fully sober for 6.5 years now. During my years of using, I experienced homelessness. I overdosed several times. I engaged in survival and criminal activity to sustain my drug use. So I definitely have, firsthand knowledge of, reality as someone who used drugs for so long, but also, of the healthcare and social service systems and barriers in Canada and especially in Quebec as I use them frequently over the years. Professionally, I've been working in substance use and sexually transmitted and bloodborne infection research for people, with people who use drugs and for people who use drugs for a couple of years now within a leading research center in Montreal and within the CRISM Quebec Node network. But today I am a consultant for Changemark and my views are my own. I've developed and implemented and evaluated peer-led recruitment strategies for a large cohort of people who inject drugs in Montreal. I personally conducted the fieldwork, analysis, knowledge translation, and I recently became a published researcher. Yay! And I work really closely with harm reduction and community organizations and networks of people who use drugs across the country, but also internationally. And finally, sorry, it's like a long introduction. I'm a public speaker and an advocate for the Nothing About Us Without Us approach in research and policy contexts. And in the MySafe evaluation, I was mostly involved in the community re-engagement plan, interview questionnaire development, as well as revising the final impact report. And I very proudly co-authored the shared purpose guide with our very, very great team. Thank you. It's a pleasure to be here.
All right, thanks both. Okay, so I'm just going to do a brief little overview of our agenda so you know what's going on in today's presentation. So we're going to kick things off with some background on MySafe and how it worked before we dive into the evaluation approaches used for this project. We'll talk a little bit about who participated in the evaluation and the different MySafe sites that were operational. Next, we'll dive into the evaluation findings, and those center around autonomy, accessibility, stability, and participants' transition experiences upon closure of the sites. And then we'll end on some lessons learned and some calls to action in relation to the findings. And then, of course, we will have some time for questions at the end of the presentation as well. That being said, please pop any questions or thoughts that you have that you would like to share with us during the presentation, and then we'll just do our best to monitor it and address them. But for now, I will hand it back over to Tara to give some background on MySafe.
Awesome, thank you. Yeah, for those who maybe don't know MySafe, let's give a little bit of a brief background of what it was, kind of how it came to be, a bit of the history, and then we'll move into our findings from the evaluation. So MySafe very simply was the first of its kind. It used biometric scanning, so the scanning of your palm to identify who you were. It would then dispense hydromorphine as prescribed by your prescriber. The intention was to reduce exposure, obviously by receiving, safe supply, so reducing exposure to street drugs that are poison, and then also to give people like dignity and choice and how they wanted to receive their medication, right? So the intention always was to give people safe supply so they didn't die, but also to give them the opportunity to access drugs as they wanted, when they needed, to then create the next levels of what they wanted to work on. We get to that in our key findings. Yeah, it wasn't just about the accessing of the dignified medication, but it was also about the peer-led model of the wraparound supports that accompanied it, right? So unlike traditional settings, people were able to access their medications without needing to engage with somebody, and then able to engage with folks as they wanted, when they wanted, to work on goals like recovery, housing, finance, connecting with family, like so many different things people wanted to work on once they had it. When I first started working with MySafe, I kind of called it like almost like housing first. Like, what does someone just need to stay alive and be stable? And then comes the next thing. So, like the model housing first, I think it came out in New York. I don't even know, like in the 2010s or something like that. It's weird to say 2010s. Yeah, so it's kind of just like, what do folks need to stay alive? And then that was the background of the MySafe. It actually originally started even before 2019. Myself, Dr. Tyndall, Mark Tyndall, and a few others, we actually just out of pocket rented our own storefront, volunteered to access folks to help them get like connected to that. And then when COVID hit, um, they kind of like the folks who decided to make policies that could or couldn't work, I guess, where it's like, oh, so you mean drug users don't need to go to a pharmacy if they just hang out a machine? Let's keep drug users in, the downtown east side, and let's just give them this machine. Everyone was trying to figure out how to. So like COVID is actually where like the shift happened, right? In which people were able to access the drugs that they needed via machine, because everyone was trying to figure out how do we keep people from not going anywhere, right? The disconnection of COVID that happened. Um, it was, to me, it was a beautiful thing to shift from surveillance to dignity, right? Is basically me. The background of MySafe was the shift from surveillance and medication to the dignity of what someone needed in order to get to the next stage. Um, so I was with MySafe from the very beginning to the very end, mostly in an operations role, just helping, making sure it was happening, a lot of the engagement, a lot of the supports. Um, After the closure, and the closure happened not because the model didn't succeed, it ended because the federal funding was cut off. And in that, I just watched so many people who were doing so well suddenly not be doing well because they didn't have medication. All the stability they found, like it was like a rug pulled out from underneath them. Even though our health authority was amazing and gave us a bit of money to like help with what they call the sunset years, to make sure that people were connected to some other services and stuff. It felt important that there was an evaluation of the program after, right? So there was many programs that were interviewed and researched, and those are all like other different organizations across Canada that did it. But the intention of MySafe was to go across Canada, provide dignified medication to folks in a way to offer stability when they wanted it, as they wanted it. And the loss of funding was devastating, and people died. And I reached out to Changemark, myself and a couple folks from MySafe, to ask, can we evaluate how the program was actually super successful because of the community support wrapped around? Like, we know safe supply saves lives, but it was the other part as well. Is like, what's the outside of just accessing safe supply, that on top of it was the success, and that was the community care and the ways that folks were able to access. So it's a bit of the background, a bit of my spiel, a bit of my frustration. And yeah, now we can kind of get into some of the findings.
So, thank you, Tara. So, in regards to the evaluation approach, so what we wanted to, Tara went over it a bit, but we wanted to see, what were the impacts while operating? So, what benefits did clients and providers see? What were the impacts of closure? What happened when access was cut off? So, when, funding stopped, essentially. And what are the lessons for the future? Like, what can we learn for scaling and sustaining similar models? Um, so this evaluation was, as mentioned, it was motivated by the program's sudden closure. And it's important to note that we didn't have access to baseline and historical data from earlier MySafe studies. So the approach of this evaluation was centered on participant voices and firsthand accounts of the immediate impact of the service and the lingering effects of its closure. Participants were recruited through they were re-engaged through former MySafe sites. We developed a clear and ethical re-engagement plan along with simple user-friendly tools to track outreach and follow-ups with former clients and service providers for this impact report. And this was especially important since quite a bit of time had passed since the program ended. And Tara, if you can remind me, I think it was maybe 12 or 18 months since the program had stopped when we started.
Yeah, it was 12 when we engaged, and then by the time we engaged Changemark, and by the time we got to talking with folks, it was closer to the 18 months.
Yeah. Okay, great, thanks. And the plan, so the plan we did was to, reconnect with sites, train peers on how to re-engage participants, document outreach and organize timelines. And also it included like how to prep for interview days. So we set up welcome booths and conducted on-site interviews in private rooms at community sites. Participants were, of course, compensated for their time. So they received $50 for the interviews, which were about 30 to 40 minutes long. 45-minute long, and $10 for the demographic questionnaire, which was about 10 minutes, maybe 15 maximum. And we used a qualitative design and were able to conduct 40 semi-structured interviews and 41 demographic questionnaires to capture the lived experiences of clients and providers throughout the MySafe lifespan. We can change slide.
Just before we jump,
yeah. Yes, of course.
I wanted to throw out just that I cannot say enough good things about the way Isabelle led the Changemark team in making sure the re-engagement was so people-centered. To have a program taken away from folks that wasn't working, not talk to them for 12 to 18 months. Well, we were talking to them, but talk to them about this. It was a sensitive way to want to engage folks to talk about how did this work for you, and so it's again referring back to our shared purpose guide. It's such a beautiful way that you, with so much thought, created the ways that you wanted to engage with folks, and then of course the whole Changemark team as well. But before we moved on to today, I just wanted to thank you for the ways that you engaged with folks with so much care.
Thank you very much. That's very kind. And indeed, it wouldn't have been possible without the whole Changemark team. So thank you. And it's been a pleasure working with you as well, Tara. So if we go on to, so the evaluation we're presenting today engaged 38 former MySafe clients and 6 service providers. And the reason why it doesn't add up with the previous slide is because some of the clients were also providers. So in some cases, they completed separate interviews with each of the hats, we could say. And so the participants included, so I'm going to breathe a second. So the service providers included peers, coordinators, and managers from 4 sites in BC that Tara will tell us about after. Before you do that, basically, the clients included, so people we re-engaged in the evaluation plan were, the median age was 46 years old, 71% of them were men, and 45% were Indigenous. Many were experiencing housing instability and financial precarity. Most of them used fentanyl and meth or methamphetamine alongside hydromorphs. In regards to housing, so 53% were living in SROs or housing with supports. Their substance use profile, as I said, like the percentages are actually 92% using fentanyl, 89 used methamphetamine, 50% were using crack cocaine, and 50% were using benzos. So a lot of them were using different substances. And 50% of the participants were not accessing prescribed alternative or OAT treatment. 24% had experienced at least one overdose in the past 6 months. So the program really focused on engaging with people who were, very much at risk of overdose with the toxic drug supply. And only 24% of them said that they always had money for basic necessities, which is really, really low. And in regards to sources of income, half of them reported engaging in illegal or survival-based income activities. So it's obvious that the program and the evaluation, as we were re-engaging, the same participants, reached really structurally vulnerable individuals and those disconnected from conventional care models. So, Tara, can you tell us about the various sites and some of the challenges that were faced with implementation?
Yeah, I sure can.
Thank
It was
you.
hard. It was hard. We're lucky in BC and in Vancouver that we do have a health authority that supports, and we do have a history of somewhat radical harm reduction. So we were able to start for the first three sites were in Vancouver. There the Overdose Prevention Society at Lugat, which was supported housing, in Carl Rooms, which is supported housing as well. Both run at the time were run by Atira. And then we were able to add a site in Victoria, working with the Kool-Aid Society. That was more of like it was when the province bought a bunch of hotels during COVID. It was one of the hotels in Victoria that were created short-term housing as they're waiting for their new housing to be built. So it was kind of transitional housing. It was important that we capture the differences between all of those places and what worked and what didn't work with it, and the big thing with it again was people having access to a machine outside of traditional clinical hours meant that people could access medication when they needed it, right? So when we're looking at some of the Atira buildings, some of the things reported were women didn't have to put themselves at risk because they were in withdrawal or craving. They could just get their medication, and if they didn't want to go out and participate in making money that day in the ways that they didn't want to, they could stay home. There's other people, if they were debt collecting happening, they didn't have to go outside and put themselves at risk because they could stay inside their house and access their medication. The Overdose Prevention Society has so much activity on a daily basis, and so a lot of the folks that were accessing the services there were using it. A lot of the staff that were working there used it, and it was really helpful in being that a site that is mostly, well, not mostly, it's all worked and run by folks that are using substances. It meant that people could have access to clean and safe drugs so that they could actually help run the consumption site, right? Like if you have folks running consumption site who are also partaking in toxic drug supply, it's hard to manage both folks overdosing, like folks using the site, and folks that are working, and so that was really helpful in helping get through when we had some of the more toxic runs through in the downtown east side. Victoria was transitional, and they did an incredible job of connecting with a lot of folks that weren't living in their traditional transitional housing, and actually a lot of outreach. So a lot of folks living outside of their housing started accessing at Kool-Aid, right? And we're able to do that again, BC, because we're under exemption 56, we're allowed to provide harm reduction life-saving services under that exemption. A lot of the other provinces, we spent all the years engaging with, talking with, so many sites wanted to, so many organizations wanted to, and it always came down to the colleges saying no, right? It was too much outside the box. Just no trust in drug users that they would know how to access their own drugs, and just saying no. Understandably, prescribers afraid to prescribe because we were told they couldn't prescribe. So it was a lot of the work that we did in all the other provinces was shut down, tied to people not wanting to work outside the box, and prescribers being kind of handcuffed and not being able to. We did get with what's called Main Street in Winnipeg. We were able to work with them and get a machine there. We didn't get to Safe Supply with that in the same levels as we got with the others because it was in the last year. But we did work really closely with them to get the machine there. People are accessing a lot of HIV and Hep C medications as well as Safe Supply because there was such an increase happening in that province for HIV and Hep C. So, it's not on here because it wasn't as much of the same program as these other four sites, but we did get a fifth machine up and running towards the end of the program. And now it's me again, isn't it? Yeah, we were trying to figure out how we were going to do the slides. And so I always forget to write down notes with it, but I have my notes. So key findings, big one was autonomy, right? When you think about one of the things that I found was the biggest is that when you were able to create autonomy for folks accessing their drugs, it was transferable. It was transformative, I meant, not transfer. It was transformative, right? Like people being able to access their own supply when they needed it, 24-hour access for the most part. It just meant that they were able to exist in the life that they wanted to leave outside that, right? There was a lot of folks that were able to pick up their medication in the morning and then go work a whole day because they didn't have to leave 4 or 5 times to go, to the pharmacy or go find street drugs. There was a lot of folks that were able to get on a different sleeping pattern so that they could actually call their parents or go meet up with them. Like they hadn't seen their I don't know, their mom forever. There's this one person I think about. He's like, after 2 months, he's like, I found my proper way to sleep. I can sleep now, and I'm gonna go see my mom for the first time in like 9 years. And I never thought that I would wake up at the right time to see her. Like it's such those little things that are so transformative in just the day to day of what people want. It's also too wasn't just about the autonomy, it was the dignity, right? Again, trusting drug users to know that what they need is again transformative. It's it's dignified, right? It's people are using drugs, they know what they need, they know what they want, and then having to not be listened to and participate in some of the more traditional settings of clinical care. Sometimes it's too much and people aren't able to participate the way that they want to. And so it's very dignified to give somebody autonomy in that. And that autonomy does lead to stabilization. It did lead to treatment. It did lead to people feeling better about themselves. Like we found so many examples of how having access in an autonomized way. Is autonomized a word? It should be. An autonomized way is that people were able to participate in life and goals that they wanted. And that was a part of the wraparound supports, is talking with people about what their goals were. Not for them to get the drugs, but once they got their safe supply, if they wanted to engage, let's talk about your goals. Let's work towards the goals. Those conversations weren't happening when they're spending the day looking for, what ways to access the drugs that they needed. And then,
Yeah, and thank you, Tara. And if we compare with what happened after the program closed, participants described feeling disempowered, anxious. They returned to really rigid provider-controlled systems, often involving lineups, limited hours, and observed dosing. And like if I put myself back in like when I personally had to do that, like that whole like when you haven't slept for days or you're in withdrawal and you need to go like on Monday morning at 9 a.m. to the pharmacy in front of like people that you feel like they're on another planet and you feel judged and stigmatized. And anyways, yeah, and how many times like did I miss, doses because of like scheduling, because I was too disorganized to at that point to, remember like, anyways, sometimes like days seemed like, anyways, I was out of it at times. And yeah, so I know like it's not from the findings, but I can very much relate like to, how they must have felt. And for many, what we found is that this shift undid the progress made during MySafe and reintroduced shame and stigma into their care experiences. So we can move on to the next slide.
yeah, it was accessible, and that was the biggest thing. It was very easily accessible, right? And when you have simple, consistent, and predictable ways of accessing the medications that you need, life just it opens up for you, right? Um, Something that's sometimes missed in there's a lot of bad media about safe supply. I don't need to get into that, but a lot of the things that were missed about MySafe is it actually led to connection to primary health care, right? So they were not just receiving their prescriptions and their medications with no access to doctors. They could only continue to receive it if they were able to meet up with their doctors. The big part of the successes of MySafe around accessibility is if you're having a hard time connecting with your doctor or your prescriber, we had peer outreach workers, we had other like site managers that would help people connect with their doctor. We had the doctors coming to the sites to meet with people. So it was like it was a bit more of a person-centered response to prescribing instead of the more traditional settings of going to someone's clinic. It's like you're saying, Isabel, it's hard sometimes to just get it together to show up during a regular business hours. But if what it is you have like peer supports that are being like waiting with you for 2 hours for you to, get what you need, maybe get you some orange juice, being like, let me help you do up your shoes. Let's go see Dr. So and so, and the person's coming along with you. It means that you get to access that doctor, you get to keep that prescription. And that's a part of the accessibility. It's not just how accessible it was, literally the palm of your hand, which again was so secure. It was like the machines were made of, you couldn't break the glass. It was like ATM strong metal. You know what I mean? The palm scan was more of a security than like your eye scan or a thumb scan because of cameras and things. And so it was so secure, but it was so accessible. And a big part of that was, again, the wrapped around spaces. And also having it at your housing in the lobby meant that people, like you already knew where you were, having it at a consumption site, you're already there using it. So kind of just breaking down sometimes some spaces can be very filled with stigma. And sometimes that is the doctor's office, that is the pharmacy. And instead bringing the medications to places you're already accessing just meant that you're more likely to access it and continue to engage with like the healthcare.
Yeah, and on the other hand, when the program ended, participants reported like the fact that care became fragmented. It was no longer centralized. They had to travel longer distances. Sometimes they missed or skipped doses, which created a lot of anxiety and disempowerment, could we say? Is that a word? Well, probably, but yeah. So not feeling empowered anymore. And in like they did state that they were like they had increased withdrawal symptoms, and sometimes what happens is like there is the physical aspect, obviously, with physical withdrawal, but there's also the psychological aspect, that if you know that you're going to be sick soon, like you're going to get even more sick. So this whole like stress of like, when am I going to get my doses? Am I going to get there on time? Like that was really, something that came up in the evaluation. Also, they return to stigmatized and negative interactions with providers, and unfortunately, like the relationships that they had created with the peers and the wraparound services, like there was they did express that like it strained the relationships, because they kind of felt like I don't know if abandoned is the right word, but it definitely created frustration. We can move on to the next slide.
Yeah, Isabel, definitely when I was talking with folks during the closure, after the closure, even before the engagement, people were feeling very abandoned, and like they were like not by the individual doctors or, the folks of MySafe, but just being like, it feels hard to be abandoned by the system again, is something that I'd heard like a few times for sure. So during MySafe, some of the key findings around stability and functioning, we kind of touched on it a bit, but like what we saw was on every level, we were seeing people identify with feeling more stable or working towards being more stable, right? Everything like health, housing, daily routines, funding, finances, like it was it was it was definitely everyone was feeling much more stable. And what, like you were saying, Isabel, is even if they were having a rough week, they knew that next week could be better because they were just going to be able to get through the week because they had access to it. So they even said that sometimes when they would feel the stabilization of the program, if they lost their footing again, they knew it was still there, and that helped them get right back to it. And like it's something that working with a lot, not myself, but working with a lot of folks in active addiction that are looking for treatment or recovery. It's those slips or those relapses that are now with such a toxic drug supply, almost a death sentence, right? So knowing that like a slip up doesn't mean like that you possibly are going to die, but it just means that you get to get back on medication is a different level of stability in the navigation of recovery and treatment. And so, it's just again having access to dignified safe supply. Like we don't need to go on and on about how stabilizing and how well that was for folks. Like we know that is why we're all here talking today.
Yeah, and after closure, the experience like really big spiral backward, where their health deteriorated. The eviction risk increased as well for those who were housed or had, temporary housing with, certain conditions and routines were, unraveled. Anxiety returned. A lot said that they lost all the progress that they had worked so hard on for the duration of the program. And I think it's clear that when we remove stability from people's lives, especially people who are already extremely structurally vulnerable, we remove the very conditions that make wellness possible. Next slide.
Yeah, absolutely. To name kind of off that, Isabelle, is one of the things that landed the hardest for me after the program closed is somebody who was thriving, and like I've probably known him 18 years in different different services and different organizations. And after it ended, he said that he wished he had never tried because he's never been more disappointed or felt like he's at like a lower place than he was before. Like, and it was because of closure, because he had reached such a stable place. The fall back for him was so big. Like it was hard to hear that, because it's again, we're kind of talking about it's out of our hands when federal funding is cut, when provincial funding is cut, when, like all the funding gets cut. It's the spiritual pain that we're all working in, and we know that there's something that could save people's lives. We know the solutions, they're right there, but they're being taken away from us and everybody, and it's hard. Um, so part of the transition is, again, our funding ended pretty abruptly, much like everybody. Well, we were never told we were going to be extended, but we kept being told, apply for another one. You never know, you never know. And we know that the funding ended in March of one year of 2024. Or that no one had told us when the funding was or wasn't gonna, if it was or wasn't gonna extend. We couldn't imagine that we wouldn't get funding for medicine, medications for folks that were saving people's lives, and then suddenly there was no more funding. It was awesome because we reached out to our health authority, who wasn't able to fund the program, but was able to fund like 3 months to help us connect everybody that we could with any of the other sources that we could, outreach with VCH, Vancouver Coastal Health, connect with people with their housing, just doing whatever we could as fast as possible in 3 months to make sure people had something that they could lean on if they wanted to. It was, again, it wasn't because the model failed. The model was extremely successful. The model failed, not the model closed because the funding ended. There was a broader shift in policy. Like we all know that there was a bunch of bad media. There became an attack on safe supply. And as it always is, it's the folks living in the marginalized sections of the folks that we support that are the ones that feel that brunt, right? So like the broad shift in policy created the ending of funding, which is why we're without MySafe and other safe supply programs across Canada. And
Yeah.
I think, is this you, Isabelle, or we on to the next one? The lessons learned is.
Yeah, we're on to the next I'm doing the next one. Yeah, sorry. Thank you. So the lessons learned, is that autonomy matters. I think we've shown today that clients were really thriving with self-dosing and dignity. It improved like self-esteem, and it was really a positive experience for them. The trust-based relationships, with peers and wraparound services, that really helped build strong, relationship with the clients. And, you know, as Tara was saying earlier, like it really goes together. It's not just a matter of like putting a machine somewhere, like it's, you know, the whole peer support that goes with it. Um, you know, and also the machines were there were a few glitches, but there was always people who were trained at the different sites to, you know, to help clients access their medication quickly or find solutions. And this was, you know, this really didn't happen often. So it was, you know, a reliable model of care, you know, that is scalable. And also the choices of sites was really important. You know, it wasn't like, oh, let's put this machine, you know, in a super clinical environment where, you know, there's all these institutional barriers. And so it was really like, you know, where people are at, and in environments where they feel comfortable, where they already have support. So that, you know, that was part of the success. You know, some of the challenges that emerged was that, you know, short-term funding made the program unstable from the beginning. So restrictive prescribing policies and liability fears also limited participation and scale. And while the evaluation was, well, the research was conducted at various sites of the program, there was no coordinated oversight or continuity in evaluation meeting opportunities. So that means that sorry, I'm having trouble. Some yeah, so some opportunities were lost to measure the long-term impact and document what worked across sites. And finally, the program was extremely vulnerable to political change, highlighting how fragile harm reduction services can be without broader system buy-in or policy safeguards. Thank you. And we can change slide.
Yeah, you know, and I don't think anything we're really sharing about the findings is surprising to anybody, but definitely like to always close out our presentations with calls to action. Like, what can you do with it other than just sit in it, right? And so for anybody who's listening or anyone who follows up and finds this, for the policymakers, you know, commit to more stable and multi-year funding to ensure continuity. Oh my gosh, what a word. Embed that same word again, so safeguards. So pilots don't have to end abruptly. Of course, we know that, right? Multi-year, not pilots. We know like multi-year, keep it going, and strengthen accountability for decisions that impact vulnerable populations.
Then, you know, call to action for health providers and researchers. So, and this is something that I personally find really amazing about this model of care, is that we can, you know, scale up biometric dispensing models for other medications. So, like, you know, the hepatitis C medication, PrEP, or, you know, even contraception pills. You know, there's all sorts of medications that can be offered through these machines when, you know, prescribed alternatives aren't an option, depending on the political context, unfortunately. So I think, you know, just, yeah, as a model of care on its own, it's a great, you know, it's something that health providers should really look into. Also, you know, always integrate wraparound supports, and design evaluation and coordination across sites for stronger evidence, because we do need stronger evidence and everything that is, you know, although like on, you know, on the ground, like we know what works and we know what doesn't, like we do need, you know, scientific evidence for policy change. So, you know, I think, yeah, so more research. Yeah, thank you.
Yeah, and then on the communities front, kind of going back to our previous webinar, and the other product we've been talking about with shared purpose is just really ensuring meaningful involvement of communities. And it's important that the involvement is actually meaningful. It's not just a box that you're checking off at the end of the day. And the meaningful involvement needs to be integrated throughout the life cycle of a project. It's not just implementation, but it's at every stage before and after that. This can be done through intentional co-design and collaborative decision-making and collaborative evaluation measures. And so what actually learning from this and taking these lessons and moving forward looks like is building something that's actually going to work for people and not making the same mistakes that have been made in the past. And so what this evaluation ultimately shows us and provides evidence towards is that pairing biometric dispensing with proper supports, as we have said over and over again, it is a scalable and person-centered model for delivering medications to people who use drugs, and it greatly enhanced the quality of their life. So as we wrap up this presentation, we do just want to take a moment to acknowledge all of the participants, all of the providers, and all of the community partners who shared their experiences for this evaluation and this project as a whole. It's really only because of these insights that we understand the impacts of MySafe and the subsequent closures, and that we have these actionable lessons to move forward with whatever comes next. But thank you all as well for your attentiveness and for listening to this presentation today. I think I'm going to tap on Rebecca now to help facilitate our Q&A session, and we'd love to hear from everyone. If you have questions and you haven't already put them in the chat, please put them in. And if you just have any thoughts or feedback that you'd like to share with us, we would love to hear that as well.
Thank you all so much. You really got my mind racing with a lot of different things to talk about. There are 2 questions, so I'm going to jump into the questions that are in our question and answer box. I'll repeat your call, Kaitlin, to everyone to say if you would like to have a comment or anything like that you'd like to discuss, please pop it in the box still. Okay, so the first question is regarding costs. How much does it cost, or how much funding would have been required to keep MySafe program going per machine, per location? And this would include the administrative and technical support costs. What does anyone have an idea of what the funding or budget?
Yeah, it'd be impossible to answer because each province, each city is different based on, cost of living, cost of where you put, like it's hard to name it. The best way I could say, and I dropped it with Tanya, is it's not the company that we use for the machine, but when we were going to do our second stage, it's the company we would have gone with for the machine. So Smart One, they're based out of Nelson, very, very affordable, very accessible. The guy who started up the company he's just amazing. He's harm reduction all over North America. So yeah, check out that gives you a bit of a pricing on the machines. Again, if you have MSP coverage, then all the medication and prescribing is covered. It's for free, so you don't have to pay for that. If it's not, then you got to think about that. For every 40 participants, so the machine could hold up to 200 and something people. For every 40 participants, you're going to want 2 peer workers. So whatever you pay your peer workers. For the most part, the machines run themselves. Again, if you have a problem, you call the machine's hotline and then they help you fix it. So it's hard to have the cost, but knowing that that's the way you would want to break it down is it going into a space you're already paying rent for, and you got to pay rent, so that would be a cost. Is your insurance covered or it doesn't cover it? Again, what site is it in? How many peers do you want? How many participants do you want? So that's kind of the ways you could figure it, but it would be impossible to unfortunately answer that. Sorry.
Can you do a ballpark around like what kind of funding you might look for? Like obviously you expand and contract what you offer based on what funding is available. But I guess part of what I'm thinking about is right now with the supervised consumption site closures, like the funding issue, and how, the idea that it's the expense, or, these are not expensive programs. That's what I'm trying to get at. And yeah, I'm thinking about supervised consumption sites that operate on like a $300,000 budget. And just, yeah, these are not expensive programs necessarily. Yeah, so just thinking about what would have been able to keep things going, and at what cost, what are the cost savings of that too?
Again, not able to answer it because the programs as they were run were not just run bare bones. They're run, funded by Health Canada with lots of evaluation, lots of research, different heads of. So you could go mad cheap. You could do it. You could do it, no problem, right? Like, but the amount of what it is to buy or rent the machine is so affordable. Again, MSP covers most of the medications, whatever you're paying your peers. Like, so it's unfortunately, you would have to figure out what you would need in order to have that. MySafe itself is we weren't able to extend, and it's the budget wasn't tied specifically to a program running cheaply out of a consumption site. It was funded to be across Canada. And a big part of the cost was evaluation. So like it's not an easy transfer bill to tell you what could have and what your sites would need. But yeah, I would encourage you to think about giving Smart One a call, finding out pricing on that. Again, it doesn't have to be safe supply. There is a lot of folks that don't have housing, that don't have a place to lock up their psych meds, their HIV meds, their Hep C meds. Like it's a very accessible way to have people access medications they need. One day we'll get back to where safe supply is a possibility, but like it's also just a smart way to have people access medications in a dignified and accessible way.
Sure. Another person is asking about the prescription. So this may be something you're able to discuss or and maybe not. So the question is, considering the toxicity of this current supply and the challenges it poses with tolerance and withdrawal, how did the program support people with multiple dependencies like opioids, benzos, tranquilizers?
Yeah, again, it was 2+ years ago. It started, up 7 years ago when we think about it starting in 2019. It's changed a lot from what was prescribed and what wasn't prescribed. What is polysubstance use? And so it's again hard to sort of answer that. It was prescriber based. It was a part of what it was is prescribers embedded in community and meeting with folks in the dignified ways that they were able to sit down and have bigger conversations, and be more creative about what somebody needed and wanted, as opposed to the cookie cutter way that sometimes more traditional settings are. So it's impossible to answer because each prescriber was different and each site was different and each city was different based on what was the people's wants at that time. But staying within what is the regulations of the College of Prescribers is kind of what you have to stay in within prescribers, and how do you get creative to make sure that and without being dismissive of it, is you don't want to give someone who's a severe alcoholic one Coors Light in the morning. That's not going to be enough. Same way with this, right? You wouldn't want someone who needs a lot more to just give them something that's not going to that is not going to not, like, they need to not be sick. They need not to have withdrawal. So yeah, the prescribing was very much based on the prescriber.
And basically, as you already said, what the machine is used for could be for any medication.
Yeah.
So in many ways, when we're talking about MySafe as a safer supply program, it was really a model for dispensing safer supply. But like as you said, could be any medication, and safer
100%.
supply, I would imagine, would and has. I know this, I don't need to imagine, it has changed over time in terms of dose, strength, types of medications, and all of that.
Yeah.
So yeah. So I'm really obsessed with thinking about some of your recommendations right now. And I gave you a little heads up that I wanted to push us further on the topic of the recommendations around sustainability. And I'm thinking about the challenge of having programs or organizations that are putting forward ideas that they want to pilot, interventions they want to pilot, particularly when they are informed by people who use drugs, the way Safer Supply was, right? Or supervised consumption sites. These are interventions that people who use drugs created for themselves to help themselves and each other. We see the benefit of this, and some people get behind this, and then look for funding to formalize it and all of that. I know that with programs funding like SUAP and such, everyone is required to do a sustainability plan. But yeah, as you talk about in your report, like, what do you do when the political winds suddenly change? I remember when we first in 2020, 2021, when the funding call started coming out, we were really excited, right? That seemed like there was political support. We were going to have this opportunity to pilot this idea. We were going to get evidence. There's been a lot of research, yeah, here we are. And despite growing bodies of research around supervised consumption sites, around safer supply, around other harm reduction interventions, evidence is not the magic bullet for policy, for changing policy, or yeah, having policy do what we want policies to do. So yeah, how do we navigate that? How do we do sustainability? What are those safeguards? And this isn't something that I expect you to answer. I just want to bring that topic up because I think that's what we're plagued with right now. All this great evidence. What do we do? How do we do sustainability?
Yeah, like I said, I don't have the answer. If I had the answer, MySafe would still be going. The consumption sites in Ontario would still be open. Like it's it's a it's hard to say because it's truly so fucked that it has to be this, but community has always been creative and caring for community. Like community's always got community. We're seeing a huge cut in funding. We're obviously going to see people die over that. We know that there's no way that's not going to happen. It's probably going to have to go back to where people are just going to have to care for themselves in the way that we did before we had the funding, right? Like that's not sustainable. I get that because it's also not just happening. We're 10 years into a crisis. The crises don't last for 10 years, right? Crisis is it's necropolitics. It's intentional. It's people are dying because of it. I don't know how to maintain financial sustainability, in it because it doesn't exist. It's like there's not a safeguard that I know, and I think if there was, there's so many brilliant people that have been doing harm reduction for so long, they would have figured it out. It's unfortunate that we do have to rely on government, and that policy does shift and change. But yeah, I don't unfortunately have that answer for you. I'm sorry.
I it's it's just very complicated, isn't it? And one of the things that I've been thinking about a lot as well, especially with safe supply and the supervised consumption site, and the political target is often very different from the actual reality of what a program is. So like this target around dispensing pills, that's not what MySafe is or Safe for Supply is. It's one piece of a bigger intervention with the wraparound supports and things like that. And so, if you target these programs with the goal of changing one piece of it, but you are dismantling all of it, right? You're throwing everything out. And that, again, that's where we see the disruptions in care being such a big deal. And why I think, again, the SCS, or even in the case of Safer Supply, where we saw people transition to other providers or transition back to the pharmacy, how that doesn't always work for people because the relationships that were created are such an integral part. Yeah. Any other questions from folks? Because, again, I just think about the impact of this this abandonment, right, of people, programs, of ideas. Yeah. And the harm that creates.
Yep, it does like I said, the spiritual pain that we as frontline workers are feeling and having to implement it or know what's coming, the pain of feeling abandoned by yet another system. Like it's just, it's the compound trauma upon the compound trauma.
Yeah. And it feels like it's been endless.
Mm-hmm.
Kaitlin, what was it, or sorry, Isabelle, what was it like for you to do this work yourself? Like from your perspective, what was your experience of getting together with people, reconnecting with people. What was that like for you?
I think it felt like I'm really happy that I was part of this project, because like I do feel like it's important to put forward different models of care that are, that out of all the solutions that we're all trying to find to save lives, and also adapt services to people who are too often excluded from services. So yeah, I think it was just an empowering experience, and also but also like from all the what we were seeing in the evaluation, it's like I could really relate to like how, like, if I put myself back in years that I was using, how that would have helped me. I could just like relate a lot to what people must have been going through. And like, earlier, like Tara, you were saying, like, even like when, let's say, like people had relapses, at least they knew they could easily get back into, like, having care. And having been personally in recovery for several years now, like how many times have I seen people who had also stopped using and went back to relapse and died. So like, anyways, like I yeah.
And we know that any transition in care, the positive ones, the difficult ones, but all transitions are periods of heightened risk, right? So
Yeah.
having that support, and I appreciated your comment about, or the point that you all made about the health authorities stepping in to help with the transition period. But a transition period for some people can take a really, really long time. To have that individualized transition plan is such an important piece, and can take such a long period of time, greater than what a funder may be able to support. There's a question here about how is this different from the 2012 Supreme Court findings? I'm thinking that must be the SES making insight legal. Yes. So do any of you want to speak to that? Why could they shut down funding for safer supply, but the Supreme Court said that insight could continue?
I honestly don't know laws enough to know. I would assume safe supply is tied to medications, and insight is tied to the act of using drugs. I imagine it's two different regulatory bodies. I don't. That's just a guess, but I don't know enough to know why they can. But also to answer, they can kind of do whatever the fuck they want, which is the unfortunate thing. One of the incredible things about Insight is it figured out how to be the Canada's first and only like safe consumption site, supervised consumption site. There'll never be another one in Canada because the Harper government went right behind and changed every single thing that the very smart people navigated around. So I don't know law, so I'm not able to speak to it. But one of the reasons we're not been able to open another like consumption site, sorry, supervised site in Canada, is because the Harper government was able to navigate all the ways that we navigate around it to not to not have it happen again. So maybe that's the answer. I'm not totally sure.
My understanding, which limited, my understanding is I attended a workshop, and I can add this to our resource list. Sorry, a workshop, a webinar by HIV Legal and some other folks. And this was last year, and they were talking about the challenges with doing like a legal action for supervised consumption sites. And when you're pulling, or safer supply, when you're pulling funding, that's a funding decision. It's not and so it doesn't mean that you're preventing something from happening. You're not barring supervised consumption. You're not barring safer supply. You're just not funding. And there are different reasons for funding things and not funding other things. So there's no breach of human rights happening there. Whereas outlawing or making something illegal, making safer supply illegal, or making supervised consumption sites illegal, that means that that's something that can be contested, looking at like using a human rights framing. So that's my understanding about that. And I think if we look at the Salome and Naomi trials, so when diacetyl morphine was being provided, there was a situation where a medication was being sourced and provided to someone and that medication wasn't available through any other channels. And so again, like unless there was a safeguard put in place, and so there, to make sure that there could be that continuity of access to diacetyl morphine. That was a key reason why that was able to be legally determined and secured. And that's why it's harder with these pilot projects, right? Like we want the idea about a pilot project is you demonstrate effectiveness, and then the healthcare system pulls that intervention into its standard operations kind of thing, and would get covered through provincial funding. But yeah, what happens when, despite evidence, it doesn't get taken up? I'll just take a moment. Oh, I don't have Tanya left, and so now you're dependent on me, everyone. So bear with me. I wanted to put into the chat a few pieces going around right now, and also invite each of you to add some more. There are a couple of petitions that are circling. Where's my list? Around the supervised consumption site closures. So I wanted to encourage folks to have a look at that. There's also an evidence brief that was compiled by Jillian Cola and Tara Gomes about supervised consumption sites and closing them. So just putting those in the chat. So there's some calls to action there. And if anyone else has any ideas about what any actions or statements, I invite you to share those as well. It was much more fun at the beginning in 2020 and 2021 when we started the community of practice, when we were all excited and sharing information and findings from getting going with these projects. It was a time of a lot of hope. Right now there's a lot of research being published, a lot of findings from studies are coming out right now, and we have a lot to share about how successful and positive outcomes, as well as challenges and lessons learned and things like that. So a lot of that's being published right now, and it's wonderful to see, and also really challenging because again, this time period of where really unsure how much evidence is actually going to be driving policy in this area. Thanks, Sam. Sam put in the chat about the UN, the UN challenge around what's going on in Canada right now. Thank you. All right, folks, shall we say goodbye for today? I do hope that people will have a look at the report. It's a beautiful report. It will be up on our website by tomorrow with the recording of the video and some other resources. I also encourage you to register for our April webinar, which will continue this theme of what happens when you have a program that is doing a good job of connecting people, helping improve stability and things like that. What happens when that care suddenly goes away? So we'll have the preliminary findings from SCS closure studies. That's happening April 26th. And yeah, I'll put that in our box too. Where's my list? I have too many windows open, problem that plagues many of us. Here it is. All right, that's in the chat. Okay, everyone. Isabelle, Kaitlin, Tara, thank you all so much for both of the webinars you've done with us. I'm really grateful for your work, and I'm very pleased to add this report to our resource library. I'm really grateful for the work you do on a day-to-day basis. Look forward to more with you.
Yeah, thank you so much for hosting us again.
Thanks all.
Sure.
Yeah, thank you.
Stop recording. Thanks for joining us today, everyone.